All right. Hi, guys. So my clinical pattern was on cervical spinal stenosis, and the age is typically over 50 years old. Gender, there really isn't any significant differences in the prevalence between genders. And then an outcome tool that's typically used is the Neck Disability Index or the Neck Pain and Disability Scale. Mechanism of injury can be disc degeneration, including bulging or protrusion of the intervertebral disc, hypertrophy of posterior longitudinal ligament, ventral spondylophyte formation, hypertrophy of dorsal facets, or thickening of the ligamentum flavum. So anything that's making that more bony growth in the cervical spine. As far as aggravating, cervical extension can be aggravating. Easing would be the opposite, cervical flexion, as well as rest and NSAIDs. 24-hour pattern, stiffness is very common, and then pain can be exacerbated by any ADLs that involve the aggravating activities like cervical extension. And then as far as a systems review or review of systems, I do think it would be important to go over some of the constitutional symptoms because we know that it can be common for metastasis in the spine. So just to clear that. Precautions and contraindications. So no use of cryotherapy or heating modalities if there's a sensation impairment at the desired treatment area. And there possibly could be sensation impairment because, as I'll talk about later, radiculopathy is common with stenosis. So, and then there's no cervical traction if they are osteoporotic or if there's suspicions of cervical myelopathy. And then for the physical exam. So what I feel like is most important to mention is that from all of my research, what I saw was that stenosis itself doesn't typically cause symptoms. It's really the presence of radiculopathy that causes symptoms to appear. So if you have a patient coming in to see you, they're experiencing symptoms, it's most likely due to radiculopathy or any kind of radicular symptoms. So my physical exam is mostly based on that. Observation, there could be a lateral head shift away from the painful side. Active movement testing, possible pain and limitation with cervical extension, ipsilateral cervical side bending and rotation. And those would be possibly pain and limited in those same motions with passive movement testing. There also could be decreased arm elevation on the involved side if they're presenting with radiculopathy. Resisted testing, possibly poor deep cervical muscle activation. And then you could see weakness seen in the muscles supplied by the affected nerve root. If they're experiencing radiculopathy, I'm going to refer y'all to my Word doc to look at the most common cervical nerve roots that are affected with this. And I have the corresponding myotomal pattern of weakness listed. Accessory motion testing, could be hypomobile cervical and thoracic glides in all cervical motions. Neurodynamics, there could be diminished or absent reflexes if they're presenting with radiculopathy. Once again, I've listed the common nerve roots affected and which reflex would be possibly affected. Palpation, there could be numbness if the patient is presenting with radiculopathy. Same thing, I've listed the common nerve roots and their corresponding distribution of sensory deficit for y'all to see on the Word doc. Special tests, these all have to do with cervical radiculopathy. So the Sperling test, which has a 30% sensitivity and a 94% specificity. Shoulder abduction test, 55% sensitivity, 85% specificity. Valsalva maneuver, 22% sensitivity, 94% specificity. Cervical distraction test, 44% sensitivity, 97% specificity, and the upper limb tension test, which is like our median ulnar and radial nerves, 97% sensitivity and 2% specificity. Differential diagnosis includes diabetic neuropathy, peripheral vascular disease, Paget's disease of the bone, spinal cord tumor, and vertebral disc disease. Diagnostic imaging, MRI, is the gold standard. It's able to show intrinsic cord abnormalities, the degree of spinal stenosis, and differentiate from other conditions. There's also a CT myelogram for those who can't obtain an MRI, and it'll identify the level of stenosis. And then extended release X-ray, it's limited value, but it can reveal dynamic instability or spondylolisthesis, which can be associated with cervical stenosis. And then signs and symptoms indicating referral to physician. So any signs and symptoms associated with cervical myelopathy, that is another clinical pattern. So please see that one to know what those signs and symptoms are. And then any neurological symptoms like gait abnormalities, fine motor changes, bowel and bladder changes that could possibly indicate a neurological syndrome associated with spinal cord compression or lesions would indicate a referral. And then, as always, no improvement of symptoms with conservative treatment. And lastly, surgical indicators or options. Surgery may be indicated if non-operative treatments are ineffective or if symptoms worsen. Also, if neurologic symptoms suggesting cervical myelopathy arise or worsen. And then some of the options include anterior cervical discectomy and fusion, laminectomy, foraminotomy, and cervical arthroplasty. All right, so that's it. Thanks, guys.